Hi, everyone, and welcome to another edition of Public Health Career Conversations. I am very happy to have with me today Dr. Shrikant Peters. Shrikant is the Medical Manager for Health in Informatics and Critical Care at Groote Schuur Hospital in Cape Town, as well as an honorary lecturer at the School of Public Health at UCT. Welcome, Shri. Thank you for joining us today to share your career journey with younger colleagues who are contemplating a step into the public health field.
Thanks kindly, Atia. Welcome to Groote Schuur Hospital.
So if anyone is curious, that is what an office in Groote Schuur Hospital looks like. Actually, the first question I have for you really is around what was the impetus for you to move into public health from clinical care? And, a lot of the younger colleagues who are contemplating public health are trying to determine what factors somebody would consider when they, decide to go into public health. And so if you could walk me through some of, your decision-making, what really sparked your interest in public health and what led you here today?
Thanks. Yeah, so I considered that question, what led me to public health? And people always ask it in an odd way. So, why did you do public health after doing medicine? And if I had to answer, I would say I did public health because I did medicine. And after graduating medicine, I found that my clinical degree didn't equip me with the tools I required, even as a junior doctor. I didn't have the skills that I needed to process the complexity around me, even though I could diagnose, and speaking as someone who's last practiced fully clinically now 10 years ago, I was able to diagnose at the top of my game in terms of what I knew as a newly qualified graduate in 2010. But processing patients through the facilities that we were sent to, everyone understands the nightmare of being on call and managing those numbers. But it wasn't that. It was the fact that patients that you treated went home and came back with another acute on chronic episode. It was that sort of level of existentialism that led me into questioning what we were doing. This revolving door of people getting sick and going out into communities and coming back into facilities. You obviously know that there's a phenomenon called the revolving door. And I think one of the first things public health gives you is a vocabulary to explain what you're seeing as an individual clinician on the ground. And we know that as the social determinants of health now. That patients and people, so people aren't patients, people are people, but they live in systems and contexts that disallow them from attaining their highest level of health and cause them to present to facilities. It's a different way of thinking of the same problem, but it helps us to look at the context that people are living in rather than necessarily just treating individuals one at a time and assigning blame. Because what you then realize is that clinical medicine is almost a one-way track to just burnout if you don't add an element of strategic management and creativity on it. And I think that's what public health, I feel, has added to my repertoire of skills. The ability to be creative, and if I'm curious, if I want to know about politics and economics, and all of these backroom deals in the Department of Health that influence clinicians' lives, if you want to know more about that, public health is the place to learn, and not just learn about it, to learn about it in a traditional apprentice-consultant relationship as a full-on specialty program. And that's what I loved about the program, and it is what I wanted out of the system. I wanted to learn more about why we have such terrible outcomes, even though we're throwing so much money at things, even though we have such good doctors and medical schools.
Mm-hmm. Thanks, Shri. So you used a word that has come up quite often in these career conversations, which is curiosity. And I think a lot of the public health practitioners that have come into the field, as you say, the skills that they had in undergrad, whether it was medicine or otherwise, didn't really explain the nuance of the patterns that they were seeing, or as you say, the revolving door of patients that, just come in and out of your facility without a long-term plan as to how to address the factors that are wider than just can be addressed in a facility. So I think that for me is always, it's something that has stuck, is that most of the public health practitioners have the sort of curiosity about the wider health system, and say the recognition that you sort of are swimming upstream if you're not, or you are on your way to burnout if you are not trying to address some of these complexities. So it seems to me that you pretty early on that public health was for you. Walk me through then what happened, after you came to that realization. What did you decide to study, and how did you then get to where you are today?
I mean, I have the opportunity, luckily being next to medical school, to speak to a lot of junior colleagues who are in a similar position in their career journeys, and very different now coming out of medical school. I mean, for us, just 10, 12 years ago, it wasn't a question of whether you would get a post, it was just where you were going to get posted. And coming out of medical school and sort of diving into internship, what I wanted was to know whether or not I was a surgical person or a medical person. I found out I'm a medical person. And I wanted to know whether or not the things I learned about myself in medical school were true. So in medical school, I was, we have the student-run free clinic service called Shorco. And so I was asked to be the clinic head for pediatrics. I was interested in pediatrics. I like to see children healthy. And obviously that's a warning sign if you think you're going into pediatrics, because you're not going to see healthy children and you're not always going to have good outcomes. And what I found about myself was that I was far more interested in making sure the clinics ran, that they had drugs, that we had a doctor working, that we had students to see the patients. Because if I wasn't doing my work, it didn't matter what else existed, the clinic didn't happen, right? And so that microcosm of Shorco compared to the rest of the health department in some ways worked far better than something as big as a tertiary facility or a district or a regional hospital that I was in for internship. And it made you question, what were the systems in place for stock control? Who was making decisions around budget? And so at the end of my community service, I was still, I knew I was medical and not surgical, and whether or not I went into something like medicine or family medicine or one of the other medical subspecialties, what I thought to myself was, if I was going into a clinical specialty, I was going into it to finish the registrar time so that I could escape the system. And I feel like a lot of people get into the specialty tracks to escape the system. And I didn't want to do that. If I was going to specialize in medicine, it meant that I was going to be there, and I was going to be there till 8 o'clock at night, 10 o'clock at night, whatever it took. Just as I was a very slow community service doctor, I was very methodical, but I was very slow, and I would leave late every single day. And I didn't want that. I didn't want that for 4 years even, just a ticket out. And so what I wanted to do was spend my time learning about the systems that fed into the hospitals, that fed into the clinics, because the problem that I think, and the frustration a lot of clinicians have, is that they've got so much knowledge about the front line and what are patterns in patient presentation, what do they need to deliver care. They know what is required. And the fact that they don't have it makes you question who is making the decision at the top. Are there any medical doctors, people with frontline experience? And then obviously you realize as you get into public health, I mean, you asked about what was my career track. From ComServe, I had done 1 year of medical officer time. So I bounced around. As an intern, I was at Addington. Big supply chain, financial difficulties there as well. Infrastructure problems in the perioperative spaces, which meant that clinicians couldn't deliver care. Some of which have been resolved over time, and I understand the complexities of managing services now as well. To the district level for ComServe in the Cape Flats, which was a highly functional space, but a very constrained environment. And then my medical officer time was 1 year in Hillbrow, which was very instructive, just to understand the kinds of patient demands that highly urbanized metropolitan areas of the country like Johannesburg have to face, including deluge of patients from outside our borders. And so after that I mean, 4 years clinical in other countries would actually qualify you as a specialist. But
Right.
after that, I had seen everything. I had started some other curricula. So I'd started looking at some courses in politics and economics through UNISA, but I'd also signed up for a master's in public health through UCT. And it was only when I had started the MPH, I was informed that there was you could actually specialize and be paid to study public health as a registrar in any other field. And so I took that opportunity, the first I could get, and obviously the MPH courses helped with that. So I did my registrar time, and by the time I finished, I was 29, and I was managing back at my old tertiary hospital, which I never expected to happen. Within public health, you are sort of reformatted as a doctor. The moment you join a public health registrar program, you come in as a clinician, you understand clinical protocols and algorithms, and you go through this somewhat intense reformatting of receiving a desk and a laptop and a set of projects to manage. And it's a very, very different playing field. You almost don't know what to do with yourself for your first few months in public health. You want a stethoscope. Mine's still hanging on my door. But then you get exposed to all of those different elements that ultimately have an impact on clinicians' lives. And so I was first posted to the Metropolitan District Health Services in the city of Cape Town. I worked under a public health specialist, and together we coordinated the work of internal medicine physicians who were managing medical referrals on the platform, looking at how many referrals they were getting, what were the ways in which they were triaging their patients, how could we standardize their processes. And subsequently, I was rotated to the district health platform, one level down, which was looking after Victoria Hospital and Bestclear and all the clinics that fed to those areas. I spent 1 year in quality assurance, looking at quality improvement projects. And in my final year, I ended up managing the perioperative services at Groote Schuur Hospital, which hasn't grown in terms of budget as much, but back in 2019, we already had a budget of R500 million for the year. So it was a really fantastic opportunity.
Thanks, Shri. So I just want to say first, before getting to some of my reflections, I'm glad that you kind of detailed what rotations you were doing, because I think a lot of colleagues want to know exactly what you would be doing when you specialize. So it's nice to hear the types of projects that you were doing and that articulation between clinical medicine. Like you say, you were working with the physicians around referral. So that's a really good example of how public health and clinical medicine articulate. But I just want to go back to the 2 points that you made. One around public health not being the default to clinical medicine. And I know there are a few people, I'm one of them, who decided to go into public health because I didn't particularly enjoy clinical medicine. But it's not necessarily the default. It's not because you don't want to do clinical medicine, you're going to public health. You have to have a passion for it, because like any other job, it has its ups and downs and its difficulties. So you could just be as miserable in public health as you would be in clinical medicine. But I also quite enjoyed you talking about understanding or testing what you thought of yourself, or your sort of self-reflection. And I think that is also an important part of one's journey, is figuring out where our natural inclinations and aptitudes are, and then selecting based on that. A lot of time especially in medical school, it's like you must become either a surgeon or a physician because it's sort of, as you say, it's expected of you. But having some sort of sense of the type of person you are and where your natural inclination takes you towards also gives you an idea on whether or not something would be a good fit for you. So having said that, I want to just talk about a little bit more. So there's two things that I just want you to unpack. Right now, you are in a medical management position. If you can maybe just talk through what that actually entails, and maybe also how your clinical but your clinical and your public health skills are utilized to in your day-to-day? And then I know you are currently setting up a diploma in medical management through the College of Public Health Medicine. And I think that would be of interest to colleagues who are thinking about medical management, and not necessarily maybe the broader field of public health, but have an interest in medical management specifically. So maybe you can just talk us through those two aspects.
Yeah. Following on from that the first project I had, and it's quite nebulous, these terms, public health, medical management as well. And it's funny that I became a medical manager, because my track to public health started with really, I use the word hate, but really disliking my medical managers. And I think the problem, and the way I saw it previously was, what did you need to be a medical manager? And we're asking those questions of ourselves now, because as a junior, very frustrated clinician, in my mind, all you needed to be a medical manager was an MBCHB and a pulse. And so what is the formation? What is the development process? What is the teaching and training required to become a manager of medical staff? And that's what we've been focusing on. Public health, like you said, there's many different opportunities. It's not just the default. People go into private consulting, they go into a straight management and MBA work. Public health, and where the skills fall into management, is that field of medicine that includes, yes, all of your epidemiology and control of the 4 major groups: infectious, non-infectious, environmental health, and occupational health, which covers pretty much your whole syllabus from medical school, but at a population health level and its control. But married to that is, your health economics, which is understanding the finances and the utility of a service, as well as management, organization, and design of services. And if you think of that's a massive task. To actually design a healthcare service, you need to understand some demography, you need to understand prevalence and incidence of disease, you need to understand a wide variety of healthcare services and treatment modalities. So you actually need to be up to date with your clinical medicine. Otherwise, you will be led by the nose by different groups of clinicians all advocating for their patients. And you also need to understand what are the priorities of the government or the organization of the day that you're working for. And so within the syllabus of public health, I think for anyone that's obviously looking to specialize in their careers, the CMSA has a breakdown of all the syllabi, all the different specialties. And if you go and look at public health medicine, they're as basic as being able to chair and minute a meeting and summarize with action points, all the way to assessing and analyzing regression models of data, and in between looking at health policy and systems, drawing up financial reports, all of the things that you know are important, but that you never learned because you were pushed and taught to manage a conveyor belt of patients and nothing else. And so those are skills that public health doctors do bring to the field of management. Now, that being said, medical managers and the roles that we play in hospital do need to come under further scrutiny. And so everyone knows there are severe budget constraints in the hospital, in the hospitals around the country and the departments, and there is no managing the way that we used to in the past. It's not enough to just have expenditure reports which just get signed off year on year. We have a decreasing budget, which means that we need to make hard decisions about the services that we're going to run and what we're going to stop. How do we measure the utility? How will we fare? And that really is where medical management comes to the fore, because we are the ones that have to coordinate a diverse set of specialties. We interact with other healthcare professionals, nurses, allied health, general workers, to create packages of care that can be delivered within resource. And that's obviously where the rubber hits the road. It's very easy to say this is the clinical best practice algorithm in vitro, but in vivo, what is possible, feasible for our country, and what will provide the best outcomes for our patients and their families. And so we're busy with this work now. We do feel that medical managers managers of other doctors, managers of specialists do need to attain and be recognized as specialists themselves. So they do need to attain those kinds of degrees. It's just never been possible. Globally around the world, in the US, in Canada and Australia, doctors who study management programs can be recognized officially by colleges of medicine in those countries as specialist managers, but it does mean they've gone through a process of formation. We are starting with a diploma program in medical management that breaks down the work of leading and managing a facility into 5 content areas. And you can imagine as a leader, anyone who has been on a ward round, I'll tell you about my day, but anyone who's been on a ward round understands the importance of a team and a leader, and knows that there is above the line management and below the line leadership. So leadership and governance is that first part of the curriculum where we teach people how to work in teams, how to inspire people, how to get the best out of individuals on a team, and to draw out this innate potential of teams to deliver better care with the same amount of resources. And you know, in the facilities that you've worked in, and people listening, that in the same settings with the same resources, teams of people who work well together and who are working according to a vision have better outcomes. You know that firm in the medical wards, you know that department in the hospital. You can see the smiles on people's faces when they work there, right? And so that's one aspect of the curriculum. The second aspect is process management, just literally understanding flow of patients in and out of facility, volumes of services that are delivered, being able to measure the volume, the efficiency of a service, and obviously the amount of money that's being put in and the amount of utility that's been gotten out. In terms of corporate governance, we look at, I imagine all managers as the midpoint of a T, in that the vertical aspect of the T is the clinical department you're managing. For some managers, it's an entire hospital with clinical departments. And the horizontal bar of the T are all the support services that are there to make sure clinicians can do their jobs. And that's financial management, human resources management, information management, supply chain, infrastructure. It's our job to make sure that these people understand that they are supporting the work of the clinicians. It's probably an upside down T. And it's our role to make sure that the work that they are doing is aligned to clinicians' work. In terms of clinical governance, it's quite unfortunate and quite sad that most clinicians would not understand what clinical governance defines, or what exactly it is. And so I actually had to get into public health before I started exploring the concept. But clinical governance is an approach to clinical work that enables excellent healthcare to flourish. It means that you are maintaining your standards, you're maintaining your standards, and you're continuously improving over time. And so this philosophy is hard, it's baked into the system, but we don't always recognize that. And sometimes we just go through the motions in fulfilling certain duties that are prescribed by a hospital. So the classic one is a morbidity and mortality meeting. Yes, you do have to gather on a monthly basis. You need to record how many people have died and how many of them were preventable. You need to put in place an action plan that seeks to overcome preventable morbidity and mortality. And that is clinical governance. And that's why it has to be done with a manager, possibly with finance in the room if there are financial implications, with nursing, with other departments. It's not possible to just, spout untruths about other departments in M&M meetings in one department. If we're doing it properly, we're having difficult, honest conversations facilitated by a medical manager. And so that's why clinical governance is also part of the syllabus. And then lastly, of course, what we're heading towards is teaching, training, and research. And so as managers, just as much as we expect our clinicians to be able to train juniors and to conduct high quality research, managers should be able to teach and train clinicians to become senior clinicians, to become heads of clinical units, heads of department one day, and to be able to manage their own departmental budgets. That's going to become very important. So the syllabus in totality is leadership and governance, clinical governance, corporate governance, process management, and teaching, training, and research. And that's what we're heading towards. It's going to take a few years before we get to a fully fledged specialty that people can do their registrar time in, but that is where we are headed.
Thanks, Shri. I think just to say, I remember you did say to me that there is a special interest group for people who are wanting to follow the progress of this. So I will post that along with your details. So anyone who wants to join the special interest group can. As you say, it may take a while to get there, but at least people will be kept abreast of developments. But I want to just reflect on your point around the teamwork. And I think it's so important. And I like the lens that you're taking in terms of skilling managers to be those leaders that they're expected to be, because a lot of the time in the healthcare system, doctors especially, but even nurses or other healthcare workers and are sort of progressed to leadership roles without the necessary background or training or even the support. If I reflect back at my time as an intern at Barra, the trauma department, which is arguably, we're in Soweto, probably one of the busiest departments, was so well run and worked and in such a team-based approach because, again, of such supported leadership. And so there wasn't ever this sort of tug of war around this is my job or your job, or I don't do this because this is beneath me. It was really run in such a efficient, streamlined manner because the leadership supported it that way, and everyone kind of knew their role and pulled in the direction that they knew that they needed to pull. So I think it is a really critical skill. Some people are natural leaders and naturally charismatic, but some people do need those skills and need to practice those leadership skills. So I think it really is an important learning as part of the entire package of medical management. So yeah, looking forward to seeing exactly how it unfolds, and I'm sure there's going to be quite a few interested colleagues who will take up the diploma in medical management, and then again, stepping stone to public health if you feel you want to see the wider health system perspective, because medical management is a part of the public health curriculum and it's one subfield within public health. So my last question really is, again, going back to our junior colleagues who are sitting at the cusp of a career decision and trying to figure out, whether they should take the plunge into public health or how they should test the waters in public health, or really just grappling with, whether they need to leave clinical medicine. If you were thinking back to, years ago when you were sitting with these decisions and you had to advise yourself, what words would you have to impart to someone watching?
A lot of people that are in that mind space, I think they realize quite quickly on is that you might not be thrilled to do what you're doing currently, but it pays the bills. And because there has been so much time in formation of a clinical doctor, never mind the fact that the task we require of them is almost impossible given the load of patients and the inability to finance the service. You always need to think 2 steps ahead, right? So yes, you're in a job perhaps that you don't specifically see yourself staying in for too long, but you need to learn how to pivot, to look at the opportunities within your current space. For myself, it was looking at internship, looking at the things that I wanted to change, and looking for opportunities to change. So in internship, and you'll see it pop up all the time on the professional groups, opportunities to do short courses, opportunities to join discussion fora at your local universities, even through SAMA. And so actually my opportunity came through SAMA when I was a member. The Foundation for Professional Development had a course called the Advanced Healthcare Management Program. It was for people who were practicing as clinicians that wanted to start quality improvement projects in their area, and there are always groups of people that are working on quality improvement. And through that, I got involved in bed flow management, in triage and implementation and training of staff in triage. And I was doing that as an intern. And you feel pulled in a certain way, even though and yes, sometimes you do burn the oil, the midnight oil, in that you do continue to deliver clinical care, and then you take on increasingly more important clinical governance roles. For some people, that's rostering. For other people, it's managing data for a registrar while you're still a junior, helping the HOD with other clinical governance tasks, setting up M&M meetings, reaching out to your medical manager and asking them how you can assist at their facility. In community service, we're seeing it more and more now. People are being allocated to healthcare districts, which is really, really interesting. And so they are line managed at a health district level, and that's a fascinating experience to have at such a junior part of your career, because you are reporting to a district director. You can see the quality assurance manager. You can see the head of pharmacy. You can see the head of HR. And they send you out as clinicians, obviously, to the clinics and the hospitals for your rotations. But you have direct access to have conversations with people that are impacting operations and strategy throughout a healthcare service. And so in the public health programs, obviously they know that people who are applying, a lot of them just have clinical experience. They'll be teasing out whether or not you've got experience of a system and whether or not you've sort of exercised your public health muscle and developed a public health lens on clinical services, on demography, on economics, on politics. It will come to the fore in an interview. Obviously, you can bolster that by looking at formal programs, diplomas. There's diplomas in health management. There's diplomas. I mean, look, any clinical diploma is going to include an element of operational management and quality improvement, and it starts to head into public health territory. There's also the formal Masters of Public Health programs, and there are a good amount of Masters of Public Health programs in the country. With those, they're not standardized. So you can do an MPH looking at health systems and policy and planning, or behavioral sciences, or economics, or straight statistics and epidemiology, which is what we will do as registrars eventually one day. So you don't necessarily have to decide upfront. Where it is strategic sometimes is to aim for an MPH program at a university that you know has a medical school with an attached School of Public Health with a public health registrar program, because it just assists when you are counting credits towards your registrar program. But if you're thinking 2 steps ahead, you are bridging yourself to different things. And I think for me, the nice thing about the MPH was, and look, I'm in theater, right? So I'm not a surgical person, as I have said. I ended up in theater because I was managing a diverse group of clinicians that nobody else wanted to manage. Surgeons, anesthetists, nurses, all fighting with each other, trying to get into the 17 operating rooms that we have around us. And because I'm a public health person, I come with that lens, and we are trusted as arbitrators in decision-making. So when I was a registrar, my first night on call, we had the head of department of HPB and the head of department of ICU disagree on a case because the one needed it for a Whipple's, a post-Whipple's procedure, and the other one wanted the bed for a Guillain-Barré that was a 17-year-old patient. And at the end of that night, the person who had to make the decision was the non-clinical registrar in public health, simply because I was arbitrating. And so in a funny way, it's a very long way around, but you have to think of where you want to get to. And in a certain way, you need to ask yourself, what do you want your daily life to look like at work? You know, what does a nice day at work look like to you? What are the interactions you have? What are the outputs you generate? And then look at the careers that fit that model. The nice thing with public health, of course, is that because it's so broad, you can make it what you want it to be. If you want to be an HIV clinician, managing a clinic, publishing papers, you've got Farid Abdullah doing that in Pretoria. If you want to interact with politicians on a daily basis and implement universal health coverage for a country, you've got Nicholas Crisp doing that. If you want to manage a global pandemic within a country and be a special advisor to a president, you just have to wait for that global pandemic to come. But when it does come, you are obviously, help me out with the name.
Prof. Abdul Karim.
Yes, you are Prof. Abdul Karim. But all of these people knew that clinical medicine wasn't necessarily for them in itself, and they took steps to reach a point where they were happy and fulfilled and satisfied. And there's a little diagram called Ikigai, where your purpose meets your skills, where those two meet. So always make sure that you know yourself, that you're 2 steps ahead in your planning. Like, yes, you may be going to ComServe next year, but what after ComServe, right? And so, and with all the application processes and with the competition that's there, you actually do need to start planning ahead. So probably by July, August of each year, you need to have applied for academic programs. You also need to make contact with people in schools of public health, heads of department of clinical units, speak to people, make sure that they know you, that they have your CV, that they've got your Z83, and then continually, wherever you are, work on items that will give you work satisfaction. When you're young and when you're starting out, just getting the drip in is great. Just being able to pull a blood culture, to be able to finish your Jimmy list for the day is work satisfaction, right? And for some people, it's doing it by 4 o'clock. For me, it was doing it by 7. But eventually, after 2 years of internship, you realize, it's not necessarily something that is meant to occur for the rest of your career. And think about the big, hairy, audacious goals that you're setting for yourself in life. Public health just has big, hairy, audacious goals. We're working on problems that some of us won't see the end of. But we are building platforms to manage future illnesses, future demographies, hopefully future better economic environments for our country. Yeah.
Thanks, Shri. I think the last point is very important around, as you say, some of us are working on things we won't see the end of. And I mean, if you were in public health or, relatively senior in your career and at the beginning of the HIV epidemic in South Africa, you certainly would not have thought that we would have been where we are today in terms of test and treat, etc. You would have seen the beginnings of it. So again, as you say, we working with a really, really long-term view, and we may not see the impacts immediately, but that's also an important thing to know. If you are somebody who wants to see people get better immediately, then you may want to consider whether or not public health is suitable for you, because you don't get that satisfaction immediately with public health. But I want to close off, my reflections on the things that you said around, Ikigai, and just thinking about your life holistically. I think, when you're younger, you seem to think that your career has a bigger role in your life than it actually has sometimes. And so you do have to think about your life holistically. And I think the point that you made about thinking through what you would like your day to look like is a really important consideration, because all jobs will have their frustrations, but by and large, you need to think about whether or not, how much you can tolerate those frustrations, and whether you need to go into another field altogether. But what I really, really liked is the point around opportunity and looking for opportunities. And for anyone interested, you can go look up this study done by a professor of psychology called Richard Wiseman, and he did a study into lucky people. And basically, quickly, what they did was they did like a research study, and they asked people how lucky they thought they were. And then what they did was they gave them a newspaper, and they said, count the number of pictures of, I don't know, dogs or cats or whatever it is. And there was a big full-page spread that said, stop counting, the answer is 50, tell the researcher, get your money, and you can be on your way. And people who thought themselves lucky were more likely to spot it. And the rationale around it is that people who are lucky are looking beyond this sort of, tunnel vision that you may have. So maybe you are looking, really got your eye on the prize for one thing, but not looking at the opportunities around you. So if I can liken it to to this, again, if you are thinking around public health medicine as a potential career, but knowing the paucity of registrar posts in the country, if that is just your singular goal, you may miss out on, as Shri says, a short course here or a little training seminar there, etc., which can give you a step in the door. And so don't feel pressured to solve for your career right now. It takes a bit of time. And so I really like the point that you made around, looking for opportunities, because there are plenty ways, to get into public health. It doesn't necessarily have to be first a specialist degree. So thank you, Shri. I've covered sort of my agenda for this discussion. Before we close, I just want to find out any parting thoughts for anyone watching out there.
Yeah, I think just the last thing, a reflection on public health and medicine. We come from a medical lens. We're talking about public health now to a medical audience primarily. But public health is so important. It can't be confined to just a medical specialty. It's a much broader field, and we interact with people who come from social science backgrounds, from political backgrounds, and that's really the joy of working in public health, working with different people from different economic backgrounds. It's really, really great. A small community actually talking big ideas. But even within medicine, and if you're not sure about public health, the skills that you learn in public health should technically feature more in undergraduate. Obviously, clinical medicine crowds out a lot of the undergraduate space. So even someone that would do short courses in public health or an MPH, those are skills that are vitally important for senior clinical practice as well. And so as someone who is on panels for clinical, for both junior and senior clinicians, when we see someone with public health skills, Masters of Public Health training, MBAs, those light up very brightly for people who want clinical posts. Everyone is competent, right? You must remember that anyone who is attending and shortlisted for an interview has passed medical school, has got their part ones, has got their intermediates. If you have someone who has gone just a little bit above the parapet and is investigating other things and has an MPH or an MBA, it really shoots the lights out. And oftentimes, any experience in research and management pushes people over the top with clinical interviews as well. So there are skills that you will learn in tracking through a public health career that are relevant across the board. And
thank you. That is yes, it's a really great reflection, and I think it is something for younger colleagues to take into consideration, because especially in the beginning of your career, you are dependent on these panels and interviews, etc., where people people don't really know you, and so they're judging you based on a piece of paper. And so anything that you can do to differentiate yourself would go a long way. So thank you for that piece of parting advice. And thank you for spending your time with us today. I'm quite sure that your insights, both into medical management and into public health, will be valuable to anyone who has even a modicum of interest in the field, and will provide some, further sort of, what is the word for it? So some further fodder for them to chew on as they make their career decisions. So thank you so much.
Great, thank you for the opportunity.